So this program was actually born of the fact that, let us start collaborating. Let us meet once in a month, um, each institution hosting this and showcasing what it is that they are doing on the African continent. From there, we are informed and we have knowledge about what is being done in their institution or with the collaborations that they have and their opportunities to partner. So for today, right now, I have the privilege of having this North American series being hosted and initiated and kicked off by Indiana colleagues. And thank you so much for being our first, I don't want to use the word guinea pig, but being our first partner to see how this is going to go. It's not just an hour of just giving lectures and what have you. It's just for us to see what it is that you have been doing. And the strength of Indiana University has been that they have been working on the African continent for over 1 to 2 decades. They're going to tell us about all it is that they've been doing. And we really want to learn about their work, their collaborations, the outcomes, and everything that they are doing. So today with me, I have Dr. Terry Vick, who is going to be co-moderating from Indiana. And he's the Indiana Hemophilia and Thrombosis Center Professor of Medicine and also a Professor of Pediatrics at Indiana University School of Medicine in Indianapolis. And his recent career activities have focused on global health and care delivery to children with blood diseases in Kenya. And as the North American Field Director of AMPATH Oncology, he leads the oncology partnership with Moore University School of Medicine and Moore Teaching and Referral Hospital to develop treatment facilities, train physicians, and auxiliary healthcare staff, and the research issues in clinical care of children and blood disorders like sickle cell disease and cancer. So with all that being said, I would let Dr. Terry continue with the Indiana way of doing things on the African continent. Thank you again for participating in this.
Yes, thank you, Aviola. It's a great honor and privilege to be here today. And I'm very happy that I've been able to bring in 3 of my colleagues to really tell you about the work on the ground that's being done. I thought, though, I would start off by giving an introduction to AMPATH, because I think that's an area that people may not know so much about. And it has some unique features which lends itself to doing global oncology work, especially in Kenya. And hopefully you can see a single slide. We'll, as I said, we'll highlight the work that we're doing in Kenya and primarily in Burkitt lymphoma in children. For those who don't know, AMPATH is an acronym for the Academic Model Providing Access to Healthcare, and it really has a tripartite mission that we'll talk about in a minute. And for today, I really wanted to talk about AMPATH itself, AMPATH oncology, drill down to AMPATH pediatric oncology, and finally down to the Burkitt lymphoma program is a model for care in Africa. And 3 of my colleagues, Ann Mormon, Sandra Langat, and Gilbert Obara, will each highlight some of the individual stories that revolve around Burkitt lymphoma care. So AMPATH really was born 3 decades ago as a partnership between Moy Teaching and Referral Hospital, Moy University, and a consortium of North American institutions led by Indiana University. And our motto is leading with care. And I think it shows in our values, which are to provide service with humility, to integrate relationships amongst colleagues in Africa and North America, to really have a commitment to the tripartite academic mission of care, training, and research, and beyond our local institutions to partner with the Ministry of Health so that we can develop sustainable health development and have it equitable and excellent. And I think that really is the mission for us. If you look back 20 years ago, the state of the art in in Western Kenya for oncology care, there really was no national cancer registry. We didn't really have screening programs for cancer. There were a couple of cobalt radiation facilities in the public sector in Nairobi, which was a long distance from us in Eldoret. There were literally 3 or 4 adult oncologists trained in the country, a handful of radiation oncologists, and there were no pediatric oncologists. But when you jump ahead to now, we've been able to build a large cancer and chronic care building. We've been fortunate to have a children's hospital freestanding in the public sector, the only freestanding children's hospital, and currently under construction is a pediatric oncology specific hospital within Eldoret in the public sector that will have over 100 beds dedicated to children with cancer. We've gotten in place 2 linear accelerators in this cancer center, and literally are seeing thousands of patients per month for radiation and for chemotherapy, and screening hundreds of thousands of women for breast and cervical cancer. As far as education goes, we have created fellowship programs, and in pediatric hematology oncology, our curriculum started about 4 years ago, and we're currently training our 6th, 7th, and 8th pediatric oncologists. All of this has been possible through grant funding, through various programs, a lot of philanthropic partners to do this, including some specific grants in flow cytometry and diagnostics in cancer that you'll hear a little bit about. So drilling down more to pediatric oncology care specifically, I think I like to highlight the fact that when you think about how patients come into care systems and pass through their journey of diagnosis, treatment, and cure, this model was developed by one of my colleagues at St. Jude, Scott Howard, and it highlights the fact that of all the cases that are diagnosed with cancer, or actually of all the cases of cancer, maybe not all of them are diagnosed, and so you have a drop-off in diagnosis. Then you have errors in diagnosis, and you can have problems where you have a improper diagnosis, so you'll lose patients that way. Once you get a diagnosis, then you have to have care available. Patients might refuse care for lots of different reasons: cost, distance to travel, and even if they start treatment, they may abandon treatment. And they then can have toxicity from chemotherapy. They can have relapse, and so from this 100% at initial, you might be in the 10 or 20% cure rate, and that really is the reality for most people even in Kenya. And what we're trying to do are increase this cure rate up to the North American standards, sort of a 60-70% cure rate or higher for many diseases. And so we really have to look at all of these problems and think about all of these ways that we can work. And so you'll hear some of the ways that we've been approaching that problem. Simply, even when you focus a narrow window on lack of diagnosis, there can be a lack of awareness by the patient, by the family, that they don't understand the symptoms. Healthcare providers may not know the symptoms. Even if you do know the symptoms, you might not have the ability to diagnose in your community. You have to travel distances to get pathology services, radiology services. And even if you have that opportunity, do you have the funds to be able to afford all of those things? And this is just one example of one part of that care model that you can think about. And so to finish up, over the last 10 years that we've been working, we have increased the number of patients that are being diagnosed and referred to our treatment center from about 80 per year in 2010 now to over 300 children with cancer per year. We've increased the survival from about 15% overall when we first started to now more than half of our children with common diseases, including Hodgkin lymphoma, ALL, Wilms tumor, and Burkitt's, are being cured. But we still have lots of opportunity for the future to increase our understanding of the biology of cancer, which and will give us some input on to train hematology and oncology physician leaders, because they, as the only ones in the country, the few of them, they are in position to advocate for the children with cancer. Identifying within our care system the optimal treatments and supports for children, using pragmatic, simple endpoint clinical trials that we can perform in Kenya is really important to make sure that we do that properly. And then reaching out to communities. I think Dr. Obaro will talk a lot about our community outreach and how we can get into the community to train people to recognize and then bring patients into care. And that's a really big part of our AMPATH Leading with Care model. So I'll end there and just remind people that we have, in addition to Moi University and Moi Teaching, Riley Hospital for Children, Indiana University. One of our biggest partners is the Prinses Maxima Center in Utrecht, in the Netherlands. The leader of that program for outreach, Gerrit Kaspers, has been a partner of mine for many years as well, since the founding. And then we've received a lot of funding over the years from various organizations that continue to support our work. So I'm going to let you go on and introduce Ann Mormon if you can. Thank you.
So jumping right into the next talk, can you see my slides?
Yes.
All right, so in keeping with what Terry started, a little bit of history to see where we started, how far we've come, and where we have to go. So a little bit of history on Burkitt's lymphoma, and then looking forward towards what have we learned that will inform any new clinical trials and how we can improve outcomes for these children. So most of you know that Dennis Burkitt was the first to publicly describe Burkitt's lymphoma when he was working in Uganda. And from there, the first virally associated cancer was described 60 years ago. So Epstein-Barr virus was isolated from a Ugandan Burkitt's lymphoma tumor. And since then, we understand that EBV is associated with many other cancers, as well as other viruses associated with other cancers. And so it's really opened an avenue of understanding how humans deal with pathogens, as well as how the pathogens can lead to cancers. Dennis Burkitt also was the first to geographically map a human cancer. So most of you familiar with this have heard of the lymphoma belt around equatorial Africa, which has the highest incidence of Burkitt's lymphoma, which is overlaid onto the malaria hot zones. And so that geographic association has led to some of the research that I will be showing you in the next few slides. Most of you are familiar with the clinical presentation of Burkitt's lymphoma and the incidence being in children 5 to 9 years of age. Typically, it's one of the highest proliferative tumors, so it's exquisitely responsive to chemotherapy. But as Terry and other people will repeat, it does not always result in cure. So African children, about 50% of them can be cured of Burkitt's with chemotherapy alone. And one of the main factors that many of us have studied is the role of EBV in continued tumor cell survival. And when children are diagnosed in sub-Saharan Africa with Burkitt's lymphoma, almost 90% of the tumors are associated with Epstein-Barr virus, whereas in the United States, about 30% of the tumors are associated with EBV. And so what is the role of the virus in continued tumor cell survival as well as treatment responsiveness? So not to belabor the EBV life cycle, but children in Africa tend to get this virus early within the first 2 years of life, and it's asymptomatic. And so it's not needed to be diagnosed or treated because the children get infected, and it's a chronic persistent herpes virus infection that infects you for life. And so by the time you're an adult, most adults are EBV positive by serology, but you're not able to detect the virus because the immune system can control that virus and keep it in check. And then malaria, as I showed you, is geographically associated. So when I started studying Burkitt's lymphoma 20 years ago, I came from the malaria field. And again, not to belabor this life cycle, transmitted this parasite by a mosquito, but the highest morbidity and mortality of malaria is children under 5. And so children who develop Burkitt's have actually survived lots of malaria. And so what has happened, to adapt to that constant exposure to malaria, and then repeat infections does lead to this premunition, which is anti-disease immunity, but it doesn't stop you from being infected with malaria. So then children can harbor chronic asymptomatic malaria infections. And so how exactly do these two co-infections that are common in children lead to a B-cell lymphoma? So this has been our working model, where children get early age EBV infection, malaria can induce lytic reactivation, and then we believe that this high burden leads to immune adaptation so that the children are no longer able to control the virus, and then the virus can lead to the c-MYC translocation and tumorigenesis. And so we've been conducting studies in Western Kenya for over 20 years, enrolling children with Burkitt's, looking where they came from. So we recapitulated the map that Dennis Burkitt did, but in Western Kenya. So the red dots are where the children with Burkitt's live, and the dark green areas are high malaria transmission. So malaria is still associated, and with some of the studies we've done, we can see this interaction with the virus and the parasite. And so the molecular evidence that malaria is involved in increasing viral loads, just going back to one of my first studies when qPCR was a new method, we tested US adults, Kenyan children from the Nandi Hills, which has low malaria, Kisumu children by the lakeside, and then Burkitt's patients. And you can see by these figures of viral load that Burkitt's patients had high viral loads, but also healthy children in high malaria areas had high viral loads as well. And then stratifying by age, you can see the youngest children before the incidence of Burkitt's are the ones that harbor the highest viral load. And then with some modeling, we looked at the duration of these high viral loads, the peaks of these viral loads, and again, it was associated with high malaria exposure. So these children are really undergoing a high burden of viral infection. So the immunologic evidence that this leads to a loss of immune control. There are two very important immune cells involved in antiviral and anti-cancer immunity, T cells and natural killer cells. So one of the first studies I did was just using a simple interferon gamma ELISpot, and again, stratifying by age and study site, we were able to see this deficiency in interferon gamma against EBNA1, which is one of the main viral proteins being expressed. We also looked further into the T cell subsets, and now with flow cytometry, some of which we can do in Eldoret, we're able to see this unconventional CD8 T cell subset that is more likely to make granzyme B instead of interferon gamma, which is perhaps less efficient at controlling the virus. And then going back to the viral loads, you see that children that have this low interferon gamma response also have higher viral loads. So they do seem to be connected. And then just one slide for natural killer cells. We have described this unconventional CD56 neg cell that has also been described in other chronic viral infections like HIV, where you see this population that's expanded in children exposed to malaria, and then also in children with Burkitt's lymphoma. And it is associated with higher viral loads, and they're poorly cytotoxic. And so these two cells that are supposed to be controlling this virus are definitely impaired in children exposed to malaria as well as the Burkitt's patients. And so what mechanism could explain the loss of T cell control over EBV? So the most likely suspect is T cell exhaustion, which many of you have heard about. And so there's a whole orchestration of immune markers that stop T cells from killing cancer cells and antiviral cells. And so these are now, we're able to study these. So in Eldoret, with the help of Dr. Tanui in the AMPATH reference lab, we're able to get tumor biopsies from patients, do single-cell RNA-seq with seqWell that Cliff O'Dour has set up, as well as doing some flow cytometry analysis and following it with immunohistochemistry staining. And so we can see differences in T cell exhaustion patterns between different patients. So the bar graph are separated by patients, and you can see these different T cell clusters and exhaustion levels within these patients, suggesting that the children can have different compositions within their tumors, and maybe that can be a marker of either terminal exhaustion or T cell exhaustion that could be recovered with immune checkpoint inhibitors. We can also, using our single-cell RNA-seq data, look at the tumor cell profiles with different markers as well as the tumors. So panel A are all looking at the tumor infiltrating lymphocytes, and B is looking at the tumors. And so if you're looking at checkpoint inhibitors that might target the cancer versus the T cells or both, you have some indication of what the composition is and which markers might be worth pursuing in a clinical trial. And so in summary, it does seem like malaria has a direct association and not just a geographic one with inducing viral loads and driving this T cell dysfunction. Those in the malaria vaccine field wonder if we'll see a decreased incidence of Burkitt's as malaria vaccines are rolled out, because we have observed over the years a decreased incidence with good malaria control programs. But these children diagnosed with Burkitt's do have a semi-exhausted T cell profile in their peripheral blood, which could possibly be used as a prognostic biomarker. And so, as I was stating, the next step is to screen these exhaustion markers within the tumors and to prioritize ICIs for preclinical studies and clinical trials to determine which hold the most promise to improve outcomes for these children. So we do have the capacity to do many of these studies now in Eldoret, and also with the collaborations of people across the partnership, being able to interpret what these data mean and make some decisions about the next steps going forward. And as Terry showed, there's a large group of people who are involved in all of these studies, and funding has been provided by the NIH as well as the Thrasher Research Fund and the Royal Society of Tropical Medicine and Hygiene. So, and most thanks goes to the children and their parents for any of these studies and questions that we ask them. So thank you very much for your attention.
Thanks, Anne. I'm not sure. I think if people have questions for any of the speakers, please feel free to just put them into the chat, and we can get to them at the end of the presentations. Since I missed Anne's introduction the first time, she has been a visiting scientist at the Center for Global Health Research in KEMRI in Kisumu for over 25 years. So that gives you a sense of her experience in the area. I think our next speaker coming up is Sandra Langat. She actually is a PhD student at Vrije University in the Netherlands in pediatric oncology, and she has been on our project team in Eldoret for over a decade, coordinating all of our clinical trials and research studies in pediatric cancer, and she's going to give us a discussion of survival of children with Burkitt's through support of diagnostic testing. Thanks, Sandra.
Thank you, Terry. I hope you can see my screen.
Yes, good.
Thank you. Okay. So as you've heard, Burkitt lymphoma is endemic across sub-Saharan Africa. It's one of the top 3 cancer diagnoses in children in our treatment center. And proper treatment is one of the many challenges in curing these children. Moi Teaching and Referral Hospital is a major treatment center for pediatric cancer in Western Kenya. And we have over 300 children who are diagnosed per year with cancer. and most of these children are treated at our center. So in 2017, we started a prospective phase 2 trial looking at interventions to improve outcomes for children with Burkitt lymphoma. In our previous work, children with cancer experienced long delays in diagnosis, and the financial burden of treatment is a significant cause of poor outcomes for our patients. So our prospective trial aimed to reduce the time to diagnosis by introducing flow cytometry and FISH genetic testing, which could be obtained free of charge by the families. We reasoned that by providing diagnostic support, this could shorten the time to make a diagnosis and therefore improve outcomes. The second aim of the study was to provide financial support to families of children diagnosed with Burkitt lymphoma to cover the cost of transportation and enrollment in health insurance, and to replace some lost income due to a family member who needed to attend to the child who was admitted. The aim of that intervention was to reduce treatment abandonment, which would in turn also improve outcomes. So in our study, we enrolled 91 patients, and the enrollment eligibility included children who are 14 years and below with a clinical suspicion of a mass that could be Burkitt lymphoma. We provided biopsy needles and coordination with the interventional radiologist or the surgical team to process samples promptly after being obtained. The study also covered the cost of flow cytometry and FISH cytogenetics to speed the diagnosis of Burkitt lymphoma. Out of the 91 patients that we included in the phase 1 of the trial, 43 children had confirmed Burkitt lymphoma. Other diagnoses were also found, as noted on the slide. The 43 patients with confirmed Burkitt's were eligible for the second phase of the trial, which included financial support. So to be eligible to our study, only a suspicion of Burkitt lymphoma was required. We did not want families to gather funds and delay performing diagnostic tests if they had to pay for them. In addition to the biopsy procedures and lab testing, we supplied needles for biopsy. We also improved the sample management process by providing a courier service to transport samples to the lab. Before our study, almost no lymphoma samples were successfully tested by flow cytometry. All these interventions reduced the time from admission to starting chemotherapy from a median of 13.6 days to 10.5 days. And for a tumor which has a doubling time of less than 1 day, that 3-day reduction was statistically and clinically significant. So the clinical characteristics of the children that had confirmed Burkitt's in our study included a mean age of 7.5 years. Boys outnumbered girls by about 2 to 1. Most children had symptoms for more than a month before arrival, and over 90% lived more than 100 kilometers from the hospital. Most children had stage 3 disease with large abdominal masses or bulky tumors. So financial assistance was given to families of children with Burkitt lymphoma. We provided transportation reimbursement to the patient and one family member for every return trip to the hospital for the 8 cycles of chemotherapy. For those children without health insurance at study entry, we supported the enrollment on NHIF. We also provided cash payments to all families at each time of returning for scheduled chemotherapy. The total financial support for this study was approximately $300 USD. Support for patients to continue on treatment reduced abandonment from the historical level of 25 to 35% down to less than 5% on our study, as you can see on the figure, which was a significant reduction. The interventions provided significantly improved event-free survival for children with Burkitt lymphoma. As you can see in our study, we had over 50% survival as compared to the historic cohort. Of note is the rapid fall in the survival curve in the first month of therapy, as you can see on the figure. So when it comes to future plans, even with diagnostic support, children are still arriving at our treatment center very late, and they are malnourished or wasted, and they have large tumors, and are more susceptible to side effects of chemotherapy, including tumor lysis syndrome, infections, or hemorrhage. So efforts to address these delays include raising awareness of childhood cancer, which we have been doing through our annual pediatric oncology course in Eldoret, which is done every January. And we'll be having our 15th annual workshop next year. We also have a bi-monthly pediatric oncology Project ECHO program for online meetings to train healthcare providers in county and mission hospitals and to create better referral networks for care. And finally, to raise awareness in the community health promoters in sub-county hospitals and health clinics. So Dr. Olbara will address some of these interventions that will help to reduce delays and hopefully impact outcomes. Thank you.
Thanks, Sandra. I'll introduce next Gilbert Olbara. He's now a fellowship-trained pediatric hematologist and oncologist at Moy Teaching and Referral Hospital. I've known Gilbert for 15 years as he's gone through all of his trainings in Eldoret, and he's been instrumental in a lot of the community outreach projects that you'll hear about. So thank you for joining us today, Gilbert.
Can you hear me, Terry?
Yes.
Can you see my first slide?
No, it's just a black screen. Maybe you should stop sharing and start again. Looks like your first slide with your disclosures. There you go.
Yes. Can you? Thank you for the warm introduction. I'll just take up from the discussions done by Terry, Professor Ann Mooman, and Sandra. So basically, I'll just highlight a few things about lessons that we've learned on how to improve referral and diagnosis of patients, because from whatever we are realizing is that all these patients are actually out there in the community. This is the work I share with a number of authors and co-investigators, as I highlighted. So this is, I'll start with where we are. This is our hospital, Shoe for Africa Hospital, Moy Teaching and Referral. We are just on the topmost floor, a small section. We have 46 beds. As mentioned, the workforce includes 2 pediatric oncologists, about 19 nurses, who are not, all of them are not oncology trained, and some support staff. If you are to picture where we are, we have seen this in Professor Mooman's presentation. Where the star is where our hospital is, and all these 22 counties or all these regions refer patients to this particular site. Then there's a big concern, however much we've discussed that there's significant advances in childhood cancer care, especially in the world, in sub-Saharan Africa, they remain pertinent issues. One of the biggest issues is underdiagnosis of childhood cancer. As you can see in this graph, based on a paper done by Ward and colleagues in Lancet Oncology, in West Africa, in this study, in West Africa, 57% of the expected 76,000 children were not diagnosed. And this is in stark contrast to European nations where only 3% of children with cancer are missed out of the diagnosis. Again, the same story we see. When you look at problems of childhood cancer treatment, this is also done by Scott Howard, and I've seen the presentation. But in my point is, when you highlight what are the problems in high-income countries, and the biggest problems is relapses, and they aim to increase their outcomes or event-free survival from 80 to 92 or 95%. But then in Africa, you have two problems. The first one is very poor outcomes, where you have event-free survivals less than 30% in majority of the countries. Then the other is that patients are not actually being diagnosed. Either you have no diagnosis, you have wrong diagnosis. Even when you get a good diagnosis, then they refuse to get treatment. So majority of the problems are before even you start treatment for this patient, or even before you get a diagnosis. And so it brings about that this is an ongoing problem that has also been realized by World Health Organization and other partners. And the problem is that you have a disproportionate increase in the burden of cancers in the high income and in the low income countries. And if we are to let this go on using the same healthcare system performance, then we'll find that 43% of the cancers in children are going to be missed in low middle income countries, accounting to about 3 million children. And the more the more important thing is that by 2050, it's postulated half of the children with cancers will actually be in sub-Saharan Africa or in low middle income countries. It's therefore imperative that we start looking at ideas on how we can improve the healthcare system, where at the end goal is to diagnose these children early and then find mechanisms of referring them for treatment as soon as possible, as mentioned by Sandra in the previous presentation. And how do we do this? And this is the basis of the Global Initiative for Childhood Cancer, by addressing the common challenges that are pertinent to sub-Saharan Africa. And so we went back to our hospital and actually did a needs assessment and looked at our challenges. And when we looked at the numbers that we were diagnosing between 2010 and 2020, we saw that, like in 2018, we were only diagnosing less than 200 children. However, when you look at the world incidence per population, you find that we are expected to diagnose about 1,200, yet we are only diagnosing 25% of this population. And that is what you'd consider as a diagnostic gap. So majority of the patients, 25% of you're only diagnosing 25% of what we expected. And this is at the point in 2020 when we started our pediatric oncology echo, which I'm going to highlight briefly. But the main point is that whereas in high-income countries, the main thing is translational research to look at the translational innovation, I think in low-middle-income countries, the thing that we need to do is social innovation. Think of ways of empowering the society or the community so that they are able to do something about diagnosis of cancer. And this has to be contextual, it has to be within the culture, and it is through collaboration, as you've seen in the presentation today. So, using some funding that we were able to get from Takeda gracefully for about 5 to 6 years, we decided to go to the community and try to see how we can improve or empower the community to be able to diagnose Burkitt lymphoma adequately. And this was using a program that we call Burkitt lymphoma program. And we appreciated the structure that was already existent in the community. The community has a preventive wing, which is what we call the community wing. And it has a clinical wing, which is actually the clinical facilities or healthcare system where you have the doctors from level 1 to level 6 hospital. That is the community hospitals all the way to the referring facilities. And we had actually a significant target. For the community wing, that is the community at large, what we wanted is to ensure that there's continuous community, empower them to be spotters of, apologies, I think just some blackout. So specifically, I hope you can hear me now.
Yes.
For the community aspect, we wanted to empower them to be able to spot us of these patients with cancer, especially Burkitt lymphoma, and also support advocacy. And for the healthcare providers was actually to recruit them for the Project ECHO, which we are going to highlight previously. And you can see there are 47 counties, but by the time we had finished, we had actually visited 22 out of the 47 counties. We had supported one pediatric oncology workshop where all the healthcare workers were there. And also we had an intersectorial regional conference to try and empower the hospitals within that area. And this included actually the administrators, the chief officers of health of those particular regions attending the meeting to discuss how to improve or collaborate in improving diagnosis. This is just an example. I will not highlight so much of a county that we visited. And what you can see is the breakdown. You have one county referral hospital, then there are several hospitals, including 20 dispensaries, which are actually building up to the county referral hospital. And the county referral hospital now refers to Moi Teaching and Referral, which was the treatment center for that particular area. So our biggest question is that going out there to the community is not sustainable. So how do we continue this? How do we think about sustainability? And that is how the idea of building an online community came up. And that is how we started to think of Project ECHO. We modeled this, and actually we were using the platform based on the Project ECHO, which was designed and discovered by Aurora. And one of the themes, if I remember in the TEDx, was the important thing was, how do you change the world first? So we took that as an idea and said, how do we change our communities first so that they are able to actually diagnose, and considering the financial implications. So we had this expertise, or the hub team in MTRH, and we've already seen that only 2 pediatric oncologists serving a whole half of western part of Kenya. Then we had these spokes participants. Those are the areas or the counties, the 22 counties that are referring to our facilities. And what we wanted to do is to empower the clinicians in this particular area to be able to help in making a diagnosis, and thus impacting more patients than what we would have impacted waiting for these patients at our hospital. So this is how the design is. So we had discovered that we were only diagnosing 25%, and this was our needs. So we wanted to get a better understanding of Burkitt's lymphoma and understanding the goals of the stakeholders, who are the people who are referring. The other next thing was the hub team, and we were able to compile a hub team, expertise from North America. We had experts at Moi Teaching and Referral in different areas, not only the pediatric oncologists, we had child life, we had the pathologists on board. Then the learning system was actually the Project ECHO platform, but also in addition, we decided also to put a WhatsApp group, and by this time we have about 1,000 members, healthcare providers who join and actually get information and actually can revisit the teachings on the WhatsApp platform. Then using the online iEcho platform, we were able to actually do the analysis, and this is what I'm going to show subsequently. This is just an example of the curriculum that we developed. It was a mixture of cancer diagnostic approaches like neck masses and differential diagnosis, common things that are common to any pediatrician or anyone dealing with children, like transfusions, but we are even also capable of actually pathology, highlighting some of the pathological issues or having the pathologists discuss the pathology or how to approach a pathological specimen. So were the participant interested? We can see these are just graphs that are showing the interest of the participants from 2020 to 2023. Just in summary is that there was progressive increase from very low levels of about 20 participants per session to, by the time we were in our 3rd year, we were actually having between 70 and 90 participants in a session. And this is replicated in the graph on our right, where you see as from the ECHO session number 1 to ECHO session number 55, there was progressive increase in interest among the healthcare providers to join the sessions every 2 weeks. Who was joining the sessions? As you can see, it was not only the physicians. We can see physicians were the majority, about 55%. But what I want to bring of interest were the physician assistants and other cadres, including the nutritionist, social worker, just emphasizing the fact that when education is provided and people are able to access, then cancer can actually be approached as a team science. Then in terms of the region, remember in the first slide, I actually showed that the west part of Kenya were the main targets, the 22 counties here. But what at the end of time, these are heat maps from this, we saw that people even from the central part of Kenya, that is Nairobi, Kenyatta National Hospital, were interested to join. And also as far as cost, who were not primarily directly referring to the patients, but it created a platform that could cover half or a significant part of Kenya, where healthcare providers could be able to get information on how best to approach their children with cancer. And these are just the summaries. By the time we were summarizing this at the end of the third year, we had 750 participants who had unique participants who had actually attended. And this actually proves that you can actually build a sustainable infrastructure to engage the community, where you have specialists being available to be consulted, and then you have patient navigators. So we created patient navigators in each of these counties or these areas who continually participated. Did it have impact on the number of diagnoses? This is just a summary, and I'll just take you to the highlighted area. What we noticed is that in counties where there was high participation, where there were on average 2.5 participants, then change in echo diagnosis was about 10 cases annually. So this was a significant thing that we noticed. Those that had low participation in each of the echo sessions had a smaller change. What it just meant is that the more the healthcare providers in this county participated, then they were able to actually increase the number of diagnoses. They were able to spot more. They were able to send these patients more to the referring or treating facility. Overall, we remember we said we had less than 200. By the time we were finishing our third year, we were almost 300 new cases per year. Then the other impact was growth of shared care centers. We said we had champions in each of these particular centers, particularly the centers where they were participating in the ECHO more frequently. And at the end of the third year, we were able to actually have 3 other centers that would participate and actually contribute experts. Like Tenwek was our expert center or shared care center, where we would even send some of our patients for surgical. Then we've already heard of Kisumu, which is a Burkitt endemic area, and it's been discussed by Professor Muman. They were actually participating significantly, and it's one of the areas that, or one of the centers that we think we can empower. Finally, we had more additional, about 70 additional cases of pediatric cancer diagnosed within each of the years, successive years. By the time we are on our third year, we are now on the 4th. Then we've seen already historical from the graph that Sandra had shown. Because of early referral, because of referral to a treatment facility, there was significant increase in survival from whatever historical numbers we were having, less than 20 or 30% to 50%. Then there were more patients being diagnosed every year. And we've tried as much as possible to share our innovations, our social innovations, by publishing some of this, sharing information so that it can be replicated, and also it can be upscaled, not only in Burkitt lymphoma, but other pediatric cancers and also adult programs within. And we are already seeing breast cancer echo carrying African echo. So it is a feasibility. It's something that is actually feasible within the sub-Saharan setting. I want to say thank you. And this is acknowledging all the members, especially Professor Terry, Taylor Severance, and Dr. Njuguna, who have been very good mentors. The Subira team, this is where all our children are being treated, and Takida for supporting some of the organization, and all of us for listening in this particular meeting. And then every small idea or seed brings up a big project. So this, we started in only a 46-bed capacity, but very soon, in a year or two, we'll have the 152-bed oncology, children's oncology only hospital that we will be able to actually actualize all the ideas that we've shared today. And with that, I wish to give back to Terry. Thank you so much.
Thank you, Gilbert. I think we have some questions in the chat. Gilbert, do you have any data on the stage at presentation as we've increased the numbers of patients being diagnosed?
Yes, thank you, Prof. Terry. So I think the initial data set that we have were actually showing that in the first 2 years, the stage of presentation was basically, most of them were presenting with advanced disease, stage 3 and stage 4, 72%, if I remember very well, for stage 3 disease, and 14% for and 14% for stage 4 disease. We had less than 5% for stage 1 disease. So there are two things basically, and this was in the first year. Then in the second year is actually replicated by, in the second and third year is what is replicated by what Sandra has presented. It had come down to 67% for stage 2 disease. For stage 3 disease, we are still yet to analyze the most recent, which covers year 3 and 4 of our Burkitt's lymphoma study. There are two challenges that is there when it comes to Burkitt's because of the rapidly progressing disease. Sometimes it's quite hard to actually get it at stage 1 and stage 2. But prompt diagnosis is actually what I think, prompt diagnosis and starting the treatment, I think is more of the game changer for this kind of presentations.
Thank you so much for this wonderful presentation. This has been so wonderful and mind blowing. I really thank the Indiana University School of Medicine and the AMPATH Oncology for this. I also have a few questions myself, and I've started writing in them. For most of which we're responding to it in real time anyways. My thought is, at some point, we should start thinking about upscaling this clinical trial to other communities and other countries, because as you know, with clinical trial actually improves the healthcare system. And we also know that innovation should not widen disparity. And then in addition to empowering the community, leading to early diagnosis, and as you've rightly seen, that just empowering the community wasn't enough, you had to empower the providers. So I was just thinking about maybe at some point what your thought process will be as far as involving policymakers, because sometimes if the healthcare system is held accountable for early diagnosis, we go out of our way to make sure that early diagnosis happen. And I hope that at some point we'll be able to start thinking about involving policymakers to make sure that this becomes a borderline malpractice thing if you don't go out of your way to ensure that the patient you're seeing gets diagnosed early. So as we're rounding up this, I know there's a lot of questions coming up. Someone just raised their hand, and we are almost at the top of the hour. I'm really trying hard for us not to exceed 12 noon, but I have so much questions that I am going to follow up with you, Terry, and people that have questions, please put it in and in the chat box so that we can continue to ask those questions in real time. And as we know, global oncology, particularly on the African continent, we have to make progress. And the only way we can make progress is by working as a group, as a team, and like I said, the Indiana University has been gracious enough to open the floor for us, and they've shown us how it's done. Not only did they come swinging, they also showed partnership and strong partnership, and this is very exciting. So for next session, which is in November, we have Belmira, can you please put it up? Next team is going to be Cornell, and then we'll be sharing will be Cornell, and then we'll be sharing the agenda and what have you for that with the whole group. Do we have any questions or anyone else that wants to say something to this? Terry, over to you or your team.
I don't know, do we have time for the one last question
Yes,
with the hand raised?
Sure, absolutely.
You can go ahead with your question. Not sure they're able to get questions. Miriam has a question. Go ahead and unmute if you can.
Sure, it's more of a comment just to commend the team, Dr. Terry, Dr. Gilbert, Dr. Langat, Prof. Moorman, really for those excellent examples around partnership and collaboration. So it's really exciting to see this series, and just commending you all and looking forward to the next series. And of course, thanking our VP North America and the AORTIC team for spearheading this. Thank you once again.
And as we move this forward, we hope that we're going to have more participation and collaboration. Indiana, please, we expect you to, we will be great privilege for you to join us, even though you won't be presenting next month. And, you know, for us to use this platform to see what others are doing, to start thinking about collaboration, you know, amongst institutions, I think we will be able to move forward stronger. All right, so it is 12 my time, which is Central Time, not African time. So I'm hoping that I just take that hour and not go above, you know. And this has been a very wonderful talk. We will try to share this discussion talk in our website for people to go back and visit it, and your emails, if possible, you know, for people to reach out to you, because I can see that there's a lot of questions. And Terry, I'm calling you right away if you can, to have a lot of discussion. This is wonderful. Thank you all for joining us. Next month is going to be Cornell that's going to be having the floor. Thank you for the AORTIC Secretariat for making this happen, and our communication director. All right, bye-bye, everybody.
Okay, thank you all.
Bye.
Thanks.